can I ask you to please take a seat? Dr. Hauser, will you please take a seat? This is the grill section of the seminar. Yes. Oh, Egil, can I ask you to please take a seat or stand as you feel comfortable? As you are aware, we have been live streaming this whole seminar, and we are so lucky that we have people who've been watching from all over the country, and in some hospitals have organized groups for their doctors and physiotherapists. I know have been watching from all over. Kan du holde den? And they have sent in some questions, and I'm going to start also with a question that is more general in nature, and that is to all three of you. I would like to ask: is fibromyalgia a disease, or is it a syndrome, condition, or a disorder? I have heard all these four words used here today, and the Norwegian authorities use the word tilstand, at det en tilstand. So is it a disease, and if so, Dr. Hauser?
It's a very philosophical question, and depends. It's a very philosophical question, and it depends on what you define what is a disease. So, Ryan, so if you look at the list of disease of the WHO organization, fibromyalgia is listed within the ICD-9 and 10. Therefore, it's an official disease.
So technically, yes, it's an official disease according to this is ICD-10.
Yeah.
Yeah.
So if you require for disease to have a defined pathophysiology, then I would say not now. Yeah. Because we do not know if these changes you have described, if they are specific for fibromyalgia, or are they valid for any kind of or a lot of chronic pain syndromes.
Right, but again, I would say that the process that we see in fibromyalgia occurs across chronic pain conditions, so we'll never find anything that is specific to fibromyalgia in my mind. That we won't see in a subset of people with low back pain, osteoarthritis, and I'll bet anyone large amounts of money that will be the case, because there's nothing about fibromyalgia it really has become sort of the human form of central sensitization. You know, because central sensitization was primarily described in animal studies and in animal models, but it really is sort of the human condition that most epitomizes central sensitization. So I totally agree with Winfried, and I think what you define this as entirely depends on how you define syndrome and disease and things like that. And I think we need to move past that, because we all acknowledge it's real.
First question.
No.
Yeah, well, it's an important question.
After that, it's like, well, what are we doing here by trying to call it a syndrome versus a disease? Or because if fibromyalgia is not a disease, then I can name 100 other medical conditions that are not a disease. If you have to have a clear pathophysiologic, but and more like 1,000 medical conditions that are not a disease. So that's, I think, everything has to be kept in context, especially for patients, because, again, I don't want you to take a clip out that said Dr. Claus said it wasn't a disease without saying, well, that's the reason Dr. Claus said that is that if you rigidly say that we have to understand the pathophysiology, then not only is fibromyalgia not a disease, but so are hundreds or thousands of other medical conditions that we are comfortable treating.
Just a small comment from me. I think it's very important to remember that pain is a subjective experience. Actually, as you know, it's defined in the definition from JASP. It's a sensory and emotional experience. But of course, it's real, and that's what I always teach the students. So that depends what you call it. It's often called such syndrome. But if you say, for instance, Wallenberg syndrome, which is a stroke in the brainstem, that's real. So that's a syndrome. So this is syndrome. It's real. So it's more important that it's a real thing and it's defined by the JASP and others. It's a real
Condition.
condition or disease or illness.
So yes and no then. But
Can I
the
use
most...
one more metaphor,
Mhm.
just to help people understand this? We get too hung up on objective factors, and we have this tendency to think that if there's an objective abnormality, that that's a disease. Those 40% of patients in the population that have a X-ray where they've lost all their cartilage, they have bone rubbing against bone, but they don't have any pain. Do they have a disease? No. Osteoarthritis, the disease osteoarthritis requires that X-ray has to be accompanied by pain.
Right.
So they don't have a disease, even though there's something very objective wrong with them. So this is all throughout. You have to be very careful about there's an objective abnormality, and thus then we're willing to make this jump. Because often, especially across the entire pain field, the objective abnormality that people find that they label the disease after often relates very poorly to the disease. Endometriosis would be an example of this. There's no relationship whatsoever in women that are given the label endometriosis between how much endometrial tissue they have and whether they have pain or not. And a lot of the women that have the same chronic pelvic pain syndromes don't have any endometriosis. So across the entire pain field, there's this disparity between what you can see objectively on an X-ray, an MRI, laparoscopy, and what the person's experiencing. And there's always a tremendous difference. But so why do we call the conditions where there is an objective abnormality a disease? That doesn't make any sense,
Exactly.
even if it has nothing to do with the pain.
Yeah. So the most important thing for us as patients, I'm representing a patient organization here today, is of course to know that it's possible that the people treating it will see it as a real disorder or whatever the definition, and can offer treatment. Because if the definition of the disease, say you get the diagnosis fibromyalgia, excludes you from treatment because it's seen as a purely cognitive or psychological disorder, then that has been the case, I know, for many patients, and these are many of the comments we get from fibromyalgia patients. They will say, I went to my doctor, blah, 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 I got the diagnosis fibromyalgia, there's nothing to do, but I should see a therapist. So that's sort of the only treatment they get. That's the reason why I'm asking this question. And now we have a question from Skogli. There's a group of physiotherapists who have been following the webinar with great interest. And I think this is a question mostly to you, Dr. Klo. In the newer light of central sensitization mechanisms and view of a continuum, as you were talking about, why should we keep the fibromyalgia diagnosis with all the unfortunate historic opinions by both health professionals and people in general?
Difficult I already answered that question. I said you can call it whatever you want. And if you think that fibromyalgia is a bad word, if it's the F word to you, or to your country, or to your healthcare system, then dump it and come up with a new term that is reflective of our current understanding. It's very real, and you can call it what you want, but it's very real.
So it doesn't matter what we call it. Great.
It does. Words matter.
Yeah.
Just if you want reimbursement, it's necessary that it's listed in the official list of diseases, and it is.
That's it. Yeah, it is necessary for all kinds of treatments and help. The words are important.
But maybe we don't know what is called in ICD-11, so we don't know.
That's true.
It only showed up just recently in ICD-10. Before then, we were using a non-specific code for muscle pain. It's a very transient appearance. Yes.
Truth doesn't last long.
Now I have a question to Egil, now representing the Norwegian doctors and scientists here. I'm going to do this in Norwegian. The question is about criterion, but it's also to make it easier for the people following. Hvilke kriterier er det som brukes nå I Norge for å diagnostisere fibromyalgi?
Do you want me to answer in
Kan du
Norwegian,
svare
norsk
på
or
norsk, for
English?
dette et sånn norsk spørsmål.
I'll answer in Norwegian.
Yeah.
It's fine with you? Well, they ask what kind of criteria we are using. We bruker de gamle kriteriene, er jeg ganske sikker på. Grunnen til at det er da ACR 1990-kriteriene som brukes fortsatt i Norge. Og grunnen til at jeg er ganske sikker på det, det er jo fordi at jeg og min gruppe holder på å validere de nye. Så de er ikke delt ut til så veldig mange enda.
Kult.
Når det er sagt, så er det slik at de er litt i bruk, og de kommer til å bli tilgjengelige nå. Så jeg tenkte at det går an å ta kontakt på NTNU, så blir dette tilgjengelig. Det er da oversatt på en vitenskapelig måte og presentert som poster. Det er ikke det. Endelig valideringsartikkelen er ikke ferdig publisert. Men det blir det forhåpentligvis. Så ja, det gamle brukes. Det nye tenker jeg kommer til å bli brukt neste år. Jeg har lyst til å stille et spørsmål selv, fordi akkurat dette med kriterier. I'll tell them we are using the 1990 criteria in Norway. That's because the new criteria, they have not been out yet, because I'm making them now with my group.
Yay! Vi heier på Egil!
And then he's helping me. He's a co-author of the article, so we have to be we are.
That's great. Them. We are very happy for this.
But I had a question for you, because we are discussing the criteria. And do you think we are getting rid of the old ACR criteria, 1990 criteria, when the new are coming? Or will you suggest that they are the supplement, the new criteria supplement? Should we get rid of the old ones, or should we still use them with the new ones? Can you use both?
Due to the rheumatologists in our German guideline, we found a compromise that we said you can use the RCR 1990 classification criteria and the new criteria. But this was only a tribute to the rheumatologist. Any other specialty want to use the new criteria, for the reason I mentioned in my lecture, because this tender point examination is nothing which is really applicable in GP practices.
Yeah, so I'm a rheumatologist and I think they're stupid. So just go ahead. I'll go against your rheumatologist any day. And yeah.
So of course there will be a period. I think very few know the new ones, and but we will have the new ones in a short while.
That's really great news for us in Norway, and I advise jeg råder alle pasientene som har fulgt med her i dag, eller ser filmen i ettertid, at dere burde få tak i disse kriteriene og gi til legene deres hvis de ikke har hørt om dem allerede.
So there have been some validation studies in several countries with the new and old criteria. And it does not matter. The rate of agreement, concordance between the old and the new criteria is very high. It does not make a difference in the clinic. The only difference is with men. You have the new criteria, you will diagnose it more frequently in men. So for you, most probably nothing will change.
Okay, we're going to move into some more specialized questions. There is a group of doctors and therapists who also been following us that say, how about all the patients who have low motivation and self-knowledge? They say this is often a problem working with patients in this group. Are they included in the studies you have been talking about? Or do they fall out or disappear from the studies?
No, this is a problem in all the studies I've been involved in, but this was what happens to a lot of chronic pain patients. They just get frustrated because they're going to different types of doctors. They're not getting treatments that are effective, or worse yet, they're being told there's nothing wrong with them or that it's all in their head. So patients with any kind of chronic pain, nothing that we've said today is specific to fibromyalgia. Our group studies 15 or 20 different chronic pain conditions, and I can't emphasize enough that some of these problems might be more pronounced in groups of patients with fibromyalgia, but none of this is specific to fibromyalgia. And again, one of the problems with some chronic pain conditions is because, like osteoarthritis, because you can see it on an x-ray, people think of it as being more real, but how do you then, it's like, well, if what you see on the x-ray doesn't at all relate to whether someone has pain or not, is that then, you know, isn't that
objective?
Yeah, isn't that, it's like, there's a circular logic that's somehow missing about those diseases. So again, these are very real problems.
Do you have a comment on that, Dr. Hauser?
Of course, these patients have been excluded, at least in the psychological studies, but there's also some approaches and also tested in studies by motivational interviewing, by educating to increase the motivation of patients to participate. So we should not expect as therapists that patients have enough motivation by themselves. So we have to help them to motivate themselves.
So that's part of the treatment then, but it should be part of the studies.
Education, motivation, it's part of the treatment.
Yeah, great. I had a question also from a patient about, since fibromyalgia, CFS and IBD often overlap, why is not diet listed as a non-medical treatment of fibromyalgia? Yeah?
Just, is it IBS probably, not IBD? No, IBD.
Also overlap. Most probably is IBS. So there are some trials, but they are small and low quality. But there might be tendency, especially in patients with IBS and fibromyalgia, that a gluten-free diet might help. And I think celiac disease is very frequent in Scandinavia. And so there are two small studies which tested it. And it had some benefit for some patients. But it's always diet, as with drugs, as with psychological therapies, it will not work for every patient.
Yeah.
But I think this is also one approach for the future.
I'm guessing also here the answer I often hear to this question is that it's impossible to make people answer truthfully what they actually have been eating over a period of 6 months or a year. So this is part of the reason why it's so hard to do good research on diet. Yeah, but I don't know if this is your experience too.
I think it's more that we just haven't studied diet and nutrition very well throughout all of medicine. It's usually left to epidemiologic studies, you know, and so I think that it's just been a poorly studied area in general.
Yeah.
I don't know any study diet for fibromyalgia, but I know that I'm participating in a study with cancer patients, breast cancer, and they try to monitor their diet for 1 year. It's very, very challenging, very challenging. So it's very difficult study to do, but it's possible.
It's possible, yeah.
Someone should do that.
Someone should do that. Another question has to do with hormones again. I remember one of you talked a little bit about hormones, and this question is, does fibromyalgia get worse during menopause? And if so, does this mean it has a hormonal cause? Or that's a bad translation. Aspect.
I mean, there's a couple things I think we can say for certain about fibromyalgia and hormones. One is it is not in any way due to the classic female sex hormones like estrogen or progesterone. Because we have these experiments of nature called pregnancy and menopause where those levels go up extremely high or go down to virtually non-existent, and they're not associated with either an improvement of or an exacerbation of fibromyalgia. The problem you see in menopause is some of the symptoms of menopause are the same as the symptoms of fibromyalgia. I know of no data that fibromyalgia gets worse in menopause, and in fact what you see in the epidemiologic studies of fibromyalgia is it actually seems to get a little bit better as people get older into their 60s and 70s, and it's a good thing that happens, because if they had really severe central sensitization superimposed upon the osteoarthritis that all of us start to develop, these people would be total wrecks. And you see that all of these conditions that are functional somatic syndromes, irritable bowel, temporomandibular joint disorder, a number of conditions have their peak incidence and prevalence in sort of age 40, 50, and then they actually seem to start to come down in frequency in the population. And so whatever this is that we're studying here, it actually does seem to get worse after puberty. I think the studies clearly show that, but it doesn't. And it slowly gets better later in life in both men and women. And I don't think that's related to menopause. That would be my opinion. I don't know. You have any?
Another question about sleep problems, which we've mentioned a little bit. That sleep problems are a big part of fibromyalgia syndrome, but could long-term sleep problems also lead to fibromyalgia syndrome, for example, in working nights? And do you see a correlance there?
Yeah, there have been a number of studies showing that people, that work on different schedules and shifts and things have more problems with conditions like fibromyalgia. And more evidence in the preclinical animal models of sleep and pain being more closely, the original studies that Harvey Moldavsky did in the 70s where he took college students and disrupted their sleep throughout their night and showed that they developed a fibromyalgia type picture. Those were too simplistic because fibromyalgia is not simply a lack of deep sleep. But still 50 or so years later, we know that a lack of deep sleep does cause pain and fatigue and some of those symptoms, and certainly it's a big contributor. And we do whatever we can, first with non-drug therapies, and then if we need to we use drugs to try to get people a deep, restful, restorative sleep.
Great. See if I can get everything. There have also been questions on research on cannabis as opposed to opioids. Is there done, or have there been done any good projects to see the difference between cannabis and opioid treatment?
Yeah, just very briefly, we've done several of these studies, and there have been a lot done in the United States. And cannabis is an effective opioid-sparing drug. In the states that put medical marijuana laws in place, in the next year or two, overdose deaths usually went down by 20 to 30%. And the fascinating thing about the medical marijuana laws is that motor traffic accidents in these states also went down. And what it looks like is happening is that there's a lot of people in the general population that self-medicate or have prescriptions. The four classes of drugs that people use to sort of de-stress are benzodiazepines, like Valium-type drugs, alcohol, opioids, and cannabis. And cannabis is probably the safest of those drugs, and it causes the least motor impairment. So the people that have been looking at these studies, and this was a big surprise, because a big concern a lot of us had about the medical marijuana laws or legalizing marijuana in certain states is, number one, that adolescent use would increase. We haven't seen that at all, because we would really be concerned about more adolescents using marijuana. It's a particularly bad drug for adolescents. And that also motor traffic accidents actually have gone down in all of these states. And what the thinking is that people, the individual people, when cannabis becomes less illegal, would rather smoke that pot to get relaxed than drink the alcohol or take the benzodiazepines, and it doesn't cause as much motor impairment as some of these other drugs.
Right. So we've heard a lot from the states about cannabinoid or medical cannabis. Has there been any research in Germany also, or through EULAR that you know, Dr. Hauser?
There will be research, but until now we have one study, but not with medical marijuana in Germany, with patients with fibromyalgia and low back pain.
Yeah, I know that there are some scientists at US, Audun Stubhaug has been talking about maybe or applying for funding for a study in Norway, but it's very still controversial here.
Yes, I'm not an expert on this, but as far as I know, you can apply for using cannabinoids for multiple sclerosis in Norway. But I think what I've seen is that the authorities, they don't refuse that it's working, but there's so many side effects, and they don't need another drug sort of in addition to alcohol. But
exactly.
as you say, maybe
you don't want to add it. Yeah.
Pardon?
Du vill inte lägga till, you don't want to add another drug.
You don't want to add another drug, but if they had invented that now and not invented alcohol, maybe they would have done that.
That's interesting. Question from a doctor who is following us here today. Any view on spironolactone for fibromyalgia? I don't even know what this is. A small study in the Scandinavian Journal of Pain around 2013 commented by Aya Kalso seemed promising, but I've seen nothing on the topic since. Spironolactone.
As well, I saw that one study, but I haven't seen any follow-up, and I don't know why it would work.
What is spironolactone?
It's a diuretic.
Okay.
But it's an unusual type of diuretic that we actually don't use very often in clinical practice.
Hypertension effect, I think.
It's potassium sparing, yeah.
Okay, we've managed to go through all the questions that have been sent in via email and Facebook from the live stream. So if there is any last comment question here, there is one. We have time for that now.
I think it's a little bit peculiar question, but on the patients which have fibromyalgia, which one cope best? People with only fibromyalgia or with other diseases? For example, with other rheumatic diseases. Which group is handling this disease better?
The plural of anecdote is data. No.
I don't think you can make a statement. There's a lot of evidence. If you look at a large group of people with different rheumatic diseases like rheumatoid arthritis and lupus and fibromyalgia, the one thing is that the fibromyalgia patients' pain levels and their functional status levels will often be worse than those of people with rheumatoid arthritis and lupus and things like that. But you were asking a question about coping, and I think within any chronic pain condition there are people that cope very well and there are people that don't cope very well, and some of the therapies, some of the cognitive behavioral therapies are trying to teach people coping strategies. So I don't think you can make a general statement that patients with fibromyalgia plus, in general, fibromyalgia plus a rheumatic disease should be more disabling than fibromyalgia alone, because there's two different elements of the disease, and it is the case that the rheumatic element of their disease we can treat a lot better now than we could 20 or 30 years ago. There have been dramatic advances in our therapy of rheumatoid arthritis and lupus and those conditions. So that component of their disease, we've had these blockbuster drugs that have been advances where for the fibromyalgia component, there haven't been the big drug advances.
I think this is a very good comment or question, and I think this reminds me of the multimorbidity issue. And I think the burden is heavier if you have multimorbid conditions. And actually, it was an article in Lancet some years ago. I think it's Barnard about multimorbidity. So the point is, if you have different or many conditions, and the burden is worse. Not so much what kind of condition you have, but the amount of them is the burden. Multimorbidity. Thank you for reminding.
We have a comment over here.
Just a short comment. I don't agree. From my patients, it seems like most of the patients have many symptoms and illnesses. And when one of them is fibromyalgia, they often say, yeah, but that's just my fibromyalgia. I have learned how to live with that. Can you look at my back, or if it's a polyneuropathy or any other diseases? So I often see that it seems like they have become more professional or heard the right things about the fibromyalgia, and they're not worrying about that anymore. That's what I see.
But that's not a contradiction what Dan Claus said. And you can have a good coping, adaptive coping in fibromyalgia only and a fibromyalgia plus rheumatoid arthritis. There's a big range of... I think we have different individual experiences, and one is burden. I think the data are clear. RA plus fibromyalgia has a higher burden, but I do not know any study if there's a difference on average in coping.
Du rekker hånda i været. This is good. I get some exercise.
Sorry. Hi, my name is Charles Bassioni. I'm a PhD candidate in medicine at the University of Oslo, and I'm specializing in treating chronic pain. And I would just like to hear a comment from each one of you in regards to what you would like to see young researchers do in the field of pain in terms of innovation or creativity, in terms of developing new projects in order to pioneer research in this field. As you know, as a young researcher, you know, where would you like to see the field grow?
This should be interesting. Vi begynner fra venstre.
You can join dance group.
He's already coming to visit.
Yeah.
We already set this up. He's coming to visit. So.
And you saw the top 10 research priorities defined by the patients in Canada. Yeah. So this could be one direction.
I think this is a terrific field for a young investigator to get into, because there really are a lot of opportunities to make fundamental new understandings. If I think back to my career in rheumatology, at the very beginning of my career, I was thinking, well, what do I want to be an expert in? Do I want to be an expert in rheumatoid arthritis or lupus, where there already have been hundreds of people studying this for decades, and it's fairly well understood that it's an inflammatory disease? Or do I want to take on this condition that no one believes that these people really have a problem? And I want to actually forge trails and use new research techniques and really show that these people have a problem, and then move forward and figure out what's the nature of the problem, what are the drug and non-drug therapies that can be effective. But looking back on my own career personally, I can't imagine a more rewarding career than one in which you take on a more difficult and what appears to be a less soluble problem. But if you apply the classic scientific principles, where you take on the right size of the problem and look, as the study that you were talking about is a really nice, cool, mechanistic study, and that's the start. And I hope it gets you excited and geeked about, 30 years from now sitting up here telling other young people how to get excited in science, and how the work that they do as a researcher really does make a difference, that it really does impact on clinical care and clinical practice. So I don't know if I answered your question, but it's do something that you're excited about, that you wake up in the morning and say, wow, if this experiment turns out to be true, then I've made a fundamental understanding in a disease that's going to lead to, again, this external vagal nerve stimulator that you're using. I think it might be an effective treatment for fibromyalgia, and what an amazing thing that would be to show that. So I don't know. You're already excited. You're already geeked, but stay that way.
I will also comment a little bit, because chronic pain, it's a very interesting field to do research in, because it's multidisciplinary. And you can have approaches both psychological, and you can have physiotherapists, you can have activity, and you can have all kinds in the field, all kinds of approaches. For instance, you can study cytokines. We have a PhD student of mine. She's sitting here, and she's doing cytokines in fibromyalgia, and we have another PhD student. He had just a study about motor systems, and Anki is an expert in motor systems in fibromyalgia, and you can do all kinds of things. And I'm very fascinated also working with this gentleman here, and I've been in Michigan. I have also been in the fMRI machine. I'm not sure if I was a control group or a patient. So it's very interesting. I recommend working with this in this field. It's very but fun and interesting.
And when it comes to science in this area in Norway, I'm very inspired by your project in Canada. And Egil has said there is funding to be had for science on chronic widespread pain and CFS in Norway. Why don't we put together a group like that with patient initiative and scientists in Norway and do it here? We're going to have to close off. Did you want to have the last question? Oi, men vi må kutte. Dette spørsmålet har ventet lenge.
This is the two last questions that came in on email. First is a question about, is there any research about the use of stem cells in fibromyalgia? And the other one is for you, Dan. Someone wanted you to repeat the name of your favorite medicine to describe to your patients.
The name of the medication is cyclobenzaprine, but that's not really very nice to tell you that it's my favorite medication when I don't think it's available in Europe. So, is it South Europe? It's available, yeah.
International pharmacy. So if you now tell it, a lot of Norwegian will buy it.
Okay. No, it really, in my hands, it's one of the most effective drugs, and it's been around forever, so it should be really cheap. It should be extremely inexpensive. In the United States, it's very inexpensive. And I'm sorry, what was the other question?
Stem cells.
Stem cells. No, we wouldn't know where to put stem cells right now. No, seriously. We have to identify the critical brain regions that are involved, and we have to know what we're targeting. We're a long ways away from stem cell therapy. That's, but again, I don't want to be disappointed to the patients in the audience. We're making tremendous progress in this field, and even the talks, today are way more optimistic and way more knowledge than they would have been 5 or 10 years or so ago. So I think people, if you're a patient, it's very frustrating, extremely frustrating year after year after year to have these symptoms, but there is a light at the end of the tunnel. There's a lot of really good work being done around the world.
Mm-hmm. Okay, with that, we will have to close this session because I know we have one distinguished guest who is supposed to reach a plane. Thank you very much for coming from both the patients and the organizers here. And we have learned so much today from your presentations. Tusen takk.